I want to address the issue of bias in public health research and use electronic cigarettes as an example of this, because people working in the field of electronic cigarettes, scientists and members of the public and others who are stakeholders, we tend to think that electronic cigarettes are somehow special, but actually there's very little difference in terms of the controversies and the way that these play out between this particular field of interest and others in public health. It's a really serious problem in public health that we really need to get to grips with. Otherwise, we're just going to find that the public have less and less confidence in the field. And when it comes to other areas, for example, pandemics and so on, we're going to be really, really stuck. So the controversy over electronic cigarettes has highlighted key weaknesses in public health research and the way it's conducted and reported. And I don't just mean reported in the media, I actually mean also reported in the scientific literature. And I've identified three of these that I think are particularly important. One of them is that we find public health scientists and people reporting public health science conveying their findings with a level of certainty that isn't warranted by the evidence that's available. I'm going to go into that in a minute. The second thing is that there is a tendency to try to lever in methodologies from clinical medicine into public health that just don't work in public health. They're not appropriate, but they're considered the gold standard because clinical medicine has essentially predominated in terms of the way that people think about the way that you have to do research. And then the third thing is the extent to which public health research suffers from biases that arise from sources that go beyond financial incentives. When you write a paper or give a talk in medicine particularly, then you fill in conflict of interest declarations, and they pretty well exclusively ask you about your financial conflicts of interest, whether you've received money from companies or whether you work for companies or have gone to conferences funded by companies and so on. But as has become very apparent in electronic cigarettes, the sources of bias go far beyond anything like that, and so we need to take that into account. So I'm just going to very briefly go through each of these. The first thing is the issue of unwarranted certainty. The fact of the matter is that in public health research, we're very largely dependent on observational data. That's to say, it's very hard to do experiments in the field, and even when we do, these are often contaminated. And so in epidemiology and public health, we try to do the best we can very often to adjust statistically for potential confounding variables. And we present our results as though we had succeeded in that. We say, for example, that we have adjusted for nicotine dependence, and therefore nicotine dependence couldn't explain our findings. But we don't have good measures of nicotine dependence. The best measures we've got are things like the Phagostrom test for nicotine dependence, or one that we've been using in my lab, which probably does a bit better than that, which is looking at urges to smoke. But we're still, with those measures, only accounting for, maybe if we're lucky, for 10 or 15% of the variance in outcomes of quit attempts. So the idea that we have adequately adjusted for nicotine dependence because we've got a variable that we've statistically adjusted for, which measures it, is optimistic. And it's not that we haven't found something out or that what we're saying should be completely discounted, but what it does mean is that we can't be certain that we have taken into account all the things that need to be taken into account, and we should express our findings accordingly. You see this in the studies on gateway effects, for example, where they say, well, we've adjusted for propensity to smoke. Well, no, you haven't really. What you've adjusted for is some variables that you've measured that have something to do with propensity to smoke. But your model of propensity to smoke is still only accounting for a small proportion of the variance. So you don't really know whether you've adjusted for that. So we need to have a little bit more humility, I think, when it comes to the way we present results. One of the tricks I've noticed in this is that very often the language will be there in the discussion section of a paper around, well, these are correlational data and therefore we can't ascribe causality and so on. But when authors then go on to talk about their findings in the media or in the conclusions section or in press releases, then that caution goes out the window and they say, yes, I'm certain, we have now demonstrated this. The second thing is the use of inappropriate methods. So we know that clinical medicine lauds the randomized controlled trial as the gold standard in research. But in public health, it's not just often impracticable or unethical, it actually doesn't produce the findings that we need. In terms of practicability and ethicality, the fact that we need informed consent in order to be able to do randomized controlled trials means we're only going to be able to do studies on people who are willing to provide that consent. What that means is that if we're comparing, for example, electronic cigarettes with another form of aid to smoking cessation, we can only do randomized controlled trials on people who don't mind whether they get an electronic cigarette or some other form of smoking cessation treatment. And as we know, that those of us who do research in this kind of area, people do have preferences. A lot of people have preferences. And so you're either going to exclude those altogether because they never even volunteer for your studies, or what often happens is they'll volunteer hoping to get one of the things that you're trying to do, the conditions, trying to test, and then when they find that they're randomized to the wrong condition as far as they're concerned, they drop out of the study. Now, there's nothing you can do about that. That's just one of the realities of doing research with humans who have a say in what happens. But it's also the case that randomized controlled trials, from initial inception to conclusion, can take 3, 4, 5 years. At a time when a field is moving on very rapidly, and not only do you need answers sooner than that, but also the thing that you were testing at the beginning may well be obsolete by the time you've even got halfway through. So the idea that the randomized controlled trial is going to be the solution to all our problems is clearly fanciful. But I'm afraid it gets worse than this, because even when we can ethically do a randomized controlled trial, and we have the money to do it and we think we can do it in the timescale, we have other problems, which is that randomized controlled trials can only typically give you binary comparisons. So you have to choose a particular control condition. Occasionally, you can do a randomized controlled trial with maybe up to 4 conditions, very expensive to do, because you need a lot of people, but maybe 3 conditions. But every time you do a binary comparison within those, you take a hit on the statistical analysis, because you're doing multiple comparisons and the probabilities of finding false positives are affected by that. So we're limited to really, really simple comparisons. So if, for example, in the case of electronic cigarettes, you have hundreds of different models and thousands of different variants on the market, you can't do randomized controlled trials to test for all those different variants. It would take you till the end of the world. So we have to bear in mind that there's only a limited number of things that we can even begin to assess. But it even gets worse than that, because in the real world of clinical trials in public health, you have typically lost to follow-up. And in smoking cessation studies, this is particularly an issue, because people who go back to smoking are often the ones who are lost to follow-up. They disengage with your study because they've gone back to smoking. So the very thing that the randomized controlled trial is giving you in terms of rigor and randomization, which allows you to ascribe causality, is busted when you have differential loss to follow-up, because you're now no longer comparing people who are randomized. You're comparing a subset who have remained in the trial, and you have to find ways of dealing with that. So the randomized controlled trial is not the gold standard in public health. There is no gold standard in public health. What we have to do is to recognize that different methods are going to be appropriate for different research questions, and we're going to need to triangulate on answers to questions using a variety of different approaches, each with its own strengths and weaknesses. And bias in the field of public health research comes from placing too great an emphasis on studies such as randomized controlled trials, when these actually can give you results which are misleading. And then the third one is something I think those people who are working in the field of electronic cigarettes are all too familiar with, which is a tendency to consider that the only source of bias that is worth considering in terms of conflict of interest are direct financial incentives, and to go further than that and say, well, anyone with some kind of financial connection, whether it's receiving travel funding or being taken out to dinner or receiving samples in order to use in the studies, or receiving payments for giving talks, anyone who does that, well, you can discount everything they say because they're tainted. This is obviously nonsense, but also it fails to take account of the fact that probably even more significant sources of bias in our field have nothing to do with money per se or direct financial incentives, and I've listed some here. For example, we all of us vary in our value systems with regards to whether we think that freedom and autonomy are critical, and therefore we have a bias towards favouring public health options which promote autonomy rather than get people to do things that the general public might think are important, versus collectivism. Some people may think, well, actually, we are all part of a connected system, and that it is appropriate to influence other people's behaviour, even if it only affects their own health, because their own health affects other people, and there's a knock-on effect. And that, like, for example, with smoking, the fact that smokers would take more days off work, for example, might, over the course of their life, cost more money to the economy, or the fact that a smoker might, people care about smokers, their family care, and other people care, and so if anything bad happens to them, it affects them. So the reality is that, for some of us, I'd probably put myself in that group, the phrase "no man is an island" or woman is very relevant, but for others, the idea of autonomy and free will and not being interfered with is important. Those value judgments make a difference to the way that we interpret ambiguous data, and all data has a level of ambiguity. Another source of bias we've obviously seen is that some people in the field consider that people on the other side are their enemies. So seeing enemies, and then it becomes more important to destroy the enemy and to do down the enemy than it does to serve the needs of public health, for example. So I think some of us are only too aware in the tobacco field that the tobacco industry is seen as an enemy, and that becomes an end in itself, doing down the tobacco industry. Now that's a value judgment, and it's fine to take that view, but it's not fine if it then influences the way that we interpret our data. Similarly, other people would see do-gooders as an enemy, and that would influence the way that data get interpreted. If you're an academic, then career advancement, getting research grants, getting papers published in top journals is a massive conflict of interest. And if it turns out that you can get a paper published in a top journal by claiming that your results are more significant and substantial or interesting than perhaps they really are, then there is a huge incentive to do that. And we see this in the e-cigarette debate, as we see it in many other areas of public health research. And of course, the journals are incentivized to publish particular kinds of article because it gets them noticed and it gets them in the press, and that helps their subscriptions, and it helps the editors, and it helps the people working on the journal and the publishers. And then, of course, we have the newspapers who are similarly wanting to raise their profile and get people to listen to what they say. So career advancement and fame has to come down as one of the key conflicts of interest that we face. But even without all that, I'm afraid that all of us, myself, everyone listening to this, all have a particular worldview, and we have an attachment to that worldview. If you're a scientist, then you may have formulated a theory or a hypothesis, and it's very easy to get attached to that hypothesis or that theory, and you see this all the time. But even if you're not a scientist, you've got a particular view of the way the world works, and we all get attached to that. And that distorts the way that we interpret evidence and results and present it. So these are key things that are going to make a difference to the way that data are interpreted, and they're very clearly evident in the electronic cigarette debate, where I've seen clearly colleagues of mine who've said, well, it is absolutely certain now that e-cigarettes are a gateway into smoking, which is absolutely not true. That it is certain, far from it. You have, on the other side, we will have people who have a very positive view of e-cigarettes, perhaps from their own experience of it, who are absolutely certain that e-cigarettes at a population level are generating hundreds of thousands of ex-smokers who wouldn't otherwise have stopped smoking. And that isn't true either. So we have to I think we owe it to ourselves, and we owe it to the people we interact with, to always be as circumspect as we can and reflective about our own views and whether it fits in with our world, whether what we're saying fits in with our worldview. So what are the solutions finally to all this? Well, I've come up with three that I think are the ones that I try and operate by. Perhaps I don't succeed all the time, but I certainly would like to aspire to these as much as possible. One of these is striving for an appropriate level of confidence rather than certainty. And by that, I don't mean doubting everything. I don't mean taking the view that nothing is known, because that's not true. What we need to do is to say, I am reasonably confident, I'm quite confident, or I'm not very confident, but I think this may be the case. And be prepared to change that as new evidence comes in. That's the key, is that with an appropriate level of confidence, you can raise or lower your level of confidence as new data comes in, always being ready to question what it is that you think. The second thing is, when it comes to data and the kinds of methodologies that we use, to apply a kind of forensic logic to public health questions, to say, well, if this were true, then surely that would be true. Let me give you an example. It is the case that there is a negative association between someone reporting having used an e-cigarette in the past and, when you follow them up, their probability of actually stopping smoking. There's a negative association. Stan Glantz at least got that right, at least with a number of studies. So you then think, well, there's a whole range of different explanations for that. And colleagues of mine who are more in favour of e-cigarettes would say, well, the obvious explanation for that is confounding by indication, which is that people who've used an e-cigarette are more dependent on nicotine and therefore find it harder to stop. And so it's rather like saying, well, aspirins don't cure headaches because people who tend to take more aspirins tend to have more headaches. In fact, aspirins cause headaches, but of course they've got the logic completely the wrong way around. That's what my colleagues say. But if that were true, then you would see a similar kind of thing for licensed nicotine products, but we don't. So with licensed nicotine products, we find that if we look at use of a nicotine product at time A while still smoking, and then we follow people up a year later, they're more likely to have stopped than people who didn't. And that's the opposite of what we see with e-cigarettes. So that explanation seems less likely to me. There are a number of other possible explanations in terms of confounding and so on, which may come into play. But there's another kind of information which you could bring to bear on this, which is the time series of the population. So if Stan Glantz were right, and there's a causal connection between using an e-cigarette and being less likely to go on to stop smoking at some point in the future, as the population has taken to e-cigarettes more and more, we would see a reduction in the rate at which people are succeeding in stopping smoking. And in the UK, where we've looked at that in quite some detail, the opposite is the case. The more people use e-cigarettes, whether it's while they're still smoking or as part of a quit attempt, we're seeing at a population level, and we published this in the British Medical Journal a few weeks ago, the higher the quit rate. So nothing is proven, but what we see is that if we bring together different kinds of methodology, we can inch our way towards answers to these questions. And then the final thing, what I try and do when looking at whether I'm likely to be biased because of all the various conflicts of interest that I have, is to apply the same standard of criticism for findings that support my view as those that conflict with that. And if we only did that, I think it would make a considerable difference, and a lot of the controversies that we find ourselves unnecessarily in would not emerge, because we wouldn't be using double standards. And we really must guard against that. And you see this all the time. I'm sure you can think of people in the field of e-cigarettes who do that, and I can as well. And maybe I do it, but I try not to. And I think we all need to try to do that. So this is a brief my take on where we stand in relation to public health, and particularly with regard to e-cigarettes, and some proposals for how we can address the issue. It's very easy to demonize one's enemies and say that, or one's opponents, people who disagree with one, and say, well, they're bastards, or they're ill-motivated or whatever, and it's a very natural thing to do. But I don't think it's very constructive. And I think that a better thing to do is to try to figure out what it is that's going wrong and how we can address that. And then the final comfort that I would like to convey is that, as I mentioned at the beginning, for those of us working in the field of e-cigarettes, 'twas ever thus. We are not alone. If you think about the MMR controversy, if we think about chronic fatigue syndrome, people working in chronic fatigue syndrome get death threats. So, it's when people get very emotional about things, then often sanity goes out the window, and e-cigarettes is no exception. Thanks for listening.